Welcome back. Thanks for staying on tonight here on In Focus. The High Court in Pretoria last week declared government's authority to decide where doctors should be deployed after completing their medical studies as unconstitutional. And following the judgment, the South African Private Practitioners Forum has hailed it as a major breakthrough. Graduate doctors had challenged the contentious deployment, saying it violated their right to decide where to work, live and practice. Observers, on the other hand, say the ruling is a major blow against the implementation of the National Health Insurance Scheme and may prove dire for rural and other underserved areas. Joining us now to share their thoughts on the ruling, Private Practitioners Forum CEO Dr. Simon Strachan and Director at the Rural Health Advocacy Group, Russell Rensburg. Good evening, gentlemen, and thank you very much for your time and for joining us tonight here on In Focus. Why is the health sector feeling triumphant today, Dr. Strachan?
Good evening, Thabo, and hello to my colleague Russell. Thabo, this has been years in the coming. In the early 2000s, there was a march on Parliament where healthcare providers were up in arms around the proposed certificate of need. And then last year, when the draft regulations were published for comment, it kind of became real that perhaps this was really starting to get some wheels onto it. The draft regulations, everybody commented on those, and there were some huge issues with that. And then the opportunity came to join the Solidarities application to declare the sections unconstitutional. And it's a victory because it's not anybody being obstructive here. This is literally looking at it going, is it right ever to determine where somebody must work, somebody must practice? And it's not just new institutions. The certificate of need was going to be applied to existing institutions in both the public and the private sector. It was almost like a license. It was going to be a criminal act to not have such a certificate of need or license, if you want that word. And it could mean, for example, myself, I've been in private practice here in Johannesburg for 26 years. There was every possibility that if it was so decided that there were too many of my type in my area, that I would not have been given a certificate. Now, the other part of this was, so that's where it ended. It said then you won't get a certificate, either as an existing establishment or a new establishment. But there was no compensation and there was no plan to then redirect, to say, well, there's a job here. Let's create a post there, or we have an opening in this area. It was just be left at that. So we are pleased that after all these years that there is clarity now that in this proposed form, the certificate of need has been declared unconstitutional. So, I think we have every right to regard it as a victory.
Yet, many are feeling that this does not then provide what alternative mechanism is there in terms of ensuring that the deployment of doctors provides for greater equitable access to healthcare, particularly for people in rural areas.
Well, that's exactly right. And that's why I'm saying this is not anybody being obstructive. And just because one is opposed to something doesn't mean we are not acutely aware of the situation and that we are against universal healthcare, which we absolutely all are, because no matter what we do, at the end of the day, there is a patient involved. But what the certificate of need also didn't do, it had no real mechanism to decide that there was overservice. So you may want to try and spread the butter across the entire slice of bread, but there's no real evidence in saying that one area is overserviced. How do you get people then to go into the more rural areas? Well, that's one around enticing people to do that. And unfortunately, that's not just providing a hospital infrastructure. Unfortunately, that is looking at the entire infrastructure system to make sure that people can live in more remote areas. And listen, when we talk about rural, we're not talking about far-flung distant places. We're talking about just a few kilometers outside the major metropolitan areas. But it does mean that we need to go back to the drawing board here, Thabo. It does mean that we need to look at how do we, with a system that is in fact constitutional, because even if this does form part of the NHI bill and there's a hue and cry now because the implementation is now scuppered a little, or perhaps there's a hurdle in place, well, we couldn't really have a bill that was being enacted with a section of it that was unconstitutional. So based on that, we do need to sit down and have a look and go, are there private facilities in more rural areas that can contract for services with the state? Let's utilize that. Is there a possibility where people in the private sector could be seconded for periods into the rural areas to work? There may be suggestions for that. And those are suggestions that are a little easier than the hardcore incentivize, improve the infrastructure across the board, make sure there are good schools, good roads, et cetera, et cetera, et cetera.
Yeah.
So it's a difficult question, and one that I think the message is, again, the certificate of need applies to both public and private. I think we just all need to sit down and get our heads together and say we are actually looking for the same thing and how best to make it work.
Russell, listening to the doctors there, I mean, what is your feeling from the Rural Health Advocacy Group point of view? Was this scheme justifiable? Maybe not necessarily well thought out, but the thinking around it, do you think it was rational and there was some logic into it?
Look, I think there's definitely some logic. Section 27 of the Constitution sort of obligates the state to ensure healthcare service to everyone, right? And unfortunately, everyone doesn't live in the places where people want to practice. So the state has to have some kind of measure to ensure that it is able to fulfill its obligation in realizing this right? The state invests heavily on behalf of taxpayers in the human capital to be able to deliver healthcare services. And every year we graduate about 1,800 healthcare professionals or doctors. That number goes up. But I think what's interesting about this particular matter that Solidarity brought, that many of the provisions that were cited in the application are really outside the kind of things that Dr. Strachan is talking about. So the rights that are afforded to medical professionals are also afforded to others. And what's particularly excluded from the application was the right to equality under Section 9, which allows the state to take certain measures to impinge on the freedom of some to advance the rights of others, because under Section 9 of the Constitution, everybody has the right to equal enjoyment of a right? And health is not like, we're not selling baked beans, we're not opening up some kind of spa. Healthcare is something that's life or death. Healthcare is an enabler that allows people to flourish, like we say in the preamble of the Constitution, of creating an environment where everybody can live out their full potential. But if we have a situation here, so some of the things cited in the applications, Section 10, the right to inherent dignity. So it's the right of healthcare workers' dignity to not work where they don't want to work. There's Section 21, freedom of movement, that people be allowed to go where they want to go. Right? None of the considerations that Dr. Strachan has raised is even affected by that right. Then there's the freedom to choose their profession. So people can go and study overseas, come back and register as healthcare professionals, and really the overall balance of the cadre of healthcare workers won't change because some people are better funded and can do that. People are not, no person is to be deprived of property. Yes, they can get that. Right? Then is the freedom of movement. So one of the provisions that we have, is not an act, it's in regulation, is community service. So community service for healthcare professionals is an opportunity for those professionals to spend 1 year working in a rural community and to get access to the broader aspects of our lives. Life in a city like Johannesburg is very different from life in rural Parabora or Lusiki or something like that, and the healthcare needs are very different. And I think our health professionals aren't always exposed or trained for those kind of environments. And the goal of the community service was really to firstly expose all healthcare professionals to rural practice. There are incentives to bring rural doctors to stay longer in rural areas, like the rural allowance, which contributes to that. But to ask that all conditions need to be in place before we consider practice outside of the environments where we want to be, I think actually impacts on the constitutional rights of the patients. And we have to put the patients at the center of this. I think maybe the certificate of need, it is vague. It hasn't been utilized in over 20 years, right? And I think, for me, I'm glad that this will go to the Constitutional Court to look at the full extent of how the rights of some, if you protect the rights of some, how it impacts on those who don't have the agency or the power to be able to shift around and access rights as and when they see fit. Yeah. And I think that's the problem with the application as it was brought, because it doesn't purely deal with the certificate of need. There's a number of different things that will allow people to do things that they want to do that may not always be in the public interest. And I'm hoping that when we get to the Constitutional Court, these things can be fully ventilated. I agree with Dr. Strachan that there are different ways that we can incentivize and resource the system. My problem here is the unintended consequences for the manner in which this particular application was brought. And I think it's totally shocking that the health department did not oppose this application. Right? I think that for me is the biggest travesty here.
Yeah.
That something as important as this, we didn't even go and defend. But at least because it has a constitutional impact, the judgment is in abeyance or is on hold until such a time that the Constitutional Court is pronounced. And I think then we can have a full reflection on it. Thank you.
Let's hope then they will be pursuing at least to make a submission in the Constitutional Court, because clearly they did not in this time. We'll continue in a moment. We'll get Dr. Mr. Strachan to respond to some of those issues that you are raising there, Russell. In a moment, you can weigh in as well, 072-110-5584, or tweet us tonight at Newzroom 405. In Focus continues. Welcome back. You're live with us tonight here on In Focus. We are with Dr. Simon Strachan, CEO of the South African Private Practitioners Forum, and Rural Advocacy Group Director Russell Rensburg. Dr. Strachan, let's talk to those issues then. The rights that you cite to practice your profession where you want to, and I suppose certainly to live and house yourself where you want to. Those rights, as much as they are constitutional rights for doctors and professionals to have, they could also have a direct and substantial impact on the patients in rural areas, and therefore may not be in the interest of the broader, I suppose, public.
Yeah, I think that's right. I think this thing about rights came out very clearly during COVID and around vaccines, and are rights shared or rights like sacrosanct. Now, look, absolutely, patients are our number one concern. If you've been running a practice in this area for 20-odd years, as I've been doing in my community depends on me. I have outreach programs into my community. I have learning opportunities for nursing sisters around vaccination clinics. All of that has been set up over time. So if I then if I don't have a certificate granted for any reason, the patients that have been using my services, their rights are also infringed. The nursing sisters, etc., the whole community therefore. But so that's why I was saying right at the beginning, it's about how thin are we going to spread this butter? And before you spread the butter, how do you know that where it's piled up is actually overserviced? So I think that the point is valid, that absolutely patients' rights must come taken into account. But it's not just the rights of patients who at the moment don't enjoy adequate healthcare facilities. It's the rights of patients at the moment who have access to healthcare facilities and who choose their healthcare from the people they want to deliver their healthcare. And I must thank Russell for going through the constitutional points of 10 and 22 and all the others, because that was the basis on which the application was made. The point now is also valid, that it has to be ratified by the Constitutional Court. So as much as we feel like it's a win at the moment, we'll have to wait and see what the final deliberation is.
Yeah. Russell, is there a mechanism of determining which area over service?
Well, I think there, Dr. Strachan is correct. Because these regulations or the act was promulgated without the minister or the Director General declaring how this thing will be operationalized, and it hasn't been. It's been inoperable for 2 decades. Right? So there's really no way of telling, and I think some provinces have dealt with this in a piecemeal way. And my sense to the accreditation, I really don't think we're ever going to get to a point where we will have an oversupply of healthcare workers in general, and that some would be forced out of business. I think the main point here is around the maldistribution. There will always be a shortage of healthcare workers. There's an 18 million shortage of healthcare workers globally, and it's growing. Now after a global pandemic, and as we prepare for the next one, I think we need to look at this last one and try and see how can we do things better. And I think, right now is a very good time for the Constitutional Court to actually reflect on this. Because when we look at COVID, almost half of patients were admitted into private facilities, right? And medical aids only cover 15% of the population, and the average cost was around 150,000 rand per patient. So there are very few who were able to pay out of pocket. Private hospitals don't employ medical doctors. Medical doctors and specialists generally work between both the public and the private sector. And I think one of the things that we saw during COVID was the capacity follows the money, because those services have delivered, and yes, those patients need a right, but I think there has to be some kind of equalizing measure. There were private, public needs to come and sit around the table and say, look, how do we find a balance between these things? We couldn't agree on a universal pricing mechanism. We couldn't agree on a universal admission criteria during COVID. We had a global pandemic, but we had 2 health system responses to it. And I think this particular application and looking at some of the other actors in it, and we can't change constitutional provisions through lawfare, right? And because at the end of the day, we know from places like Brazil, there's a lot of unintended consequences with this, right? And hopefully when going into the constitutional court hearings and maybe in those processes, I think everybody can come together and we can find a balance. I doubt any private practitioner will ever be out of business, right? I think the matter is just where they choose to practice. How do we bring out a balance? How do we bring new entrants into the area? Yeah. How do we foster greater cooperation between the public and the private sector in a unified way? Yeah. Because, well, I'm of the view that we'll always have a private sector. You know, Section 26 or 25 of the Constitution, it talks about the right to divide, that you can't be deprived of property, goes to intellectual property as well, right? But we all have to come back to that primary I like, firstly, Section 10. You know, everybody has the right to inherent dignity, and everyone, not some, right? And we have to figure out how the two work together. Section 27, everyone has the right to health care, and health care is scarce. So let's find a way that we can find a balance to ensure that we can meet the basic healthcare needs of the broader population, and that we can work together in some way to reduce some of the inconsistencies between the public and private healthcare systems, which in some instances compete for resources at the moment, rather than work together in a unified way. And I'm glad that this matter was brought forward so that we can actually have an opportunity to have this issue ventilated. Because just laying it there and leaving it vague and leaving it invasive makes everybody uncertain. So I think this is an opportunity for people to come together. This is an opportunity to bring new perspectives and ideas to it, and hopefully find a resolution, right? But I'm just concerned with some of the unintended consequences on other policies like the community service policy and so forth.
Completely out of time. We're going to have to leave it there. Gentlemen, I appreciate you. Thank you very much for coming on, Dr. Strachan and Russell Rensburg there, and your interventions with us here this evening.